Welcome to AETCM, the emergency medicine channel. Shall we start, sir? A 47-year-old male came to ER with complaints of recurrent episodes of vomiting and uncontrolled restlessness since today morning. On initial 10-second assessment, airway was patent, no pooling of secretions. Breathing respiratory rate was 20 breaths per minute. SpO2 100% on room air. Circulation heart rate was 90 beats per minute. BP was 160 by 80 mmHg. Coming to disability, GCS was E4, V5, M6. Pupils were equally and bilaterally reacting. On exposure, patient was afebrile but visible sweating was present. Coming to adjuvants to primary survey, we took an ABG showing pH of 7.534 with bicarb of 25.5, metabolic alkalosis with potassium 3.6 and sodium 136.
What are the reasons for metabolic alkalosis? It's not very common.
No,
you don't see metabolic alkalosis in your practice commonly.
Hypochloremic metabolic alkalosis is seen in vomiting.
Hypochloremic, okay.
Or post, if we give bicarbs also, we can see metabolic.
So that is very rare. Bicarb given in a patient, normal patient, is very, very rare. Main thing is vomiting. Vomiting is a major reason for metabolic alkalosis. Okay. Rarely some type of renal tubular diseases can also, but normally it produces acidosis. Some conditions you can get alkalosis. Otherwise it is not at all common. Vomiting is the one.
Coming to sample history, patient is a known case of substance use disorder. Since last 3 years, he has been injecting heroin 3 to 4 times per day since last 3 years. Last taken was 3 days back. Now came to ER with complaints of vomiting around 30 to 40 episodes since yesterday, with reduced sleep, generalized body ache, also complaints of abdominal cramping type of pain associated with 2 to 3 episodes of loose stools. He also reports of feeling restless, anxious and frustrated since last 3 days. No history of fever, no history of chest pain, palpitation, no history of shortness of breath, no history of other substance like alcohol or stimulants like cocaine or methamphetamine intake, no history of suicidal ideations. According to we have a clinical assessment. According to all these symptoms, we came to a conclusion that patient had last taken 3 days back, so it can be a withdrawal of opioids. We have a clinical assessment tool for withdrawal of opioids, and we can assess
Scoring
accordingly whether the patient is having mild, moderate or severe withdrawal symptoms. Components involves resting pulse rate. If it is less than 80,
happened to the pulse rate?
It was 90 here.
What will happen now?
Usually increases. Patient will be restless. Resting pulse rate is, according to scoring system, it can be 0, 1, 2, 4. 0 is less than 80, 1 is 81 to 100, 2 is 101 to 200, 4 is more than 120. Sweating over the past half an hour. 0 is no reports of chills or flushing. 1 is subjective reports of chill and flushing. 2 is flushed or presence of moisture on the face. 3 is beads of sweat on the brows or face. 4 is sweating streaming off the face. In this patient, beads of sweat was seen on brows and face. Restlessness 0, able to sit still. 1 reports difficulties sitting still but is able to do. 3 frequent shifting of movements. 5 is unable to sit for more than few seconds. Here the patient was frequently shifting of movements of both legs and arms. Coming to pupil size, 0 is normal in size, 1 is larger than normal, 2 is moderately dilated, 5 is pupil dilated, only rim of the iris visible. Here pupils were normal in size, so it was 0. Bone aches and joint aches, 0 is normal, not present, 1 is mild discomfort, 2 is patient reports of diffuse muscle aches. Here patient was having diffuse muscle aches, 0.2. 4 is for patient rubbing the joints and muscle is unable to sit down. Coming to running nose, 0 is not present, 1 is nasal stuffiness or moisture, 2 is nose running, 4 is nose constantly running. Here patient did not have any running nose. Coming to GI symptoms.
What was the score in this patient? Mild,
moderate withdrawal symptoms. Total score was 18. 5 to 12 is mild, 13 to 24 is moderate, 25 to 30 is moderately severe, more than 30 is severely.
Okay.
So according to the scale, the patient had moderate withdrawal, so we started him on symptomatic treatment for anxiety.
So what are the
irritability.
common symptoms of withdrawal of opioids?
In the initial, within 12 hours, patient will be anxious, frustrated. Patient will feel like he has to take the drug. After 12 hours, patient will have restlessness, agitation, abdominal cramping, pain, tachycardia, yawning,
BP,
hypertension, flushing. More than 12 to 36 hours, patient will have piloerections, yawning, hiccups, sweating.
Okay. So how do you manage this case?
Sir, if it is moderately severe or severe withdrawal, we can give partial agonist.
First, when the patient come to ER in a state of moderate opioid withdrawal, what all things you do?
First,
moderate.
If it is moderate, we can treat the patient symptomatically. In withdrawal, what happens is that...
So first, what do you do when the patient come to ER? Don't tell me the theory.
First
is airway, breathing, circulation. Airway, there will not be any problem here. Breathing, there will not be any problem till late stages. Circulation,
tachycardia and hypertension.
So what is the first thing you will do for the patient?
First,
you have to put an IV line. It's a very simple answer. Unless until you put an IV line, you cannot treat the patient, because these patients may require hydration, these patients may require alpha blockers. Okay, so you require an IV line first. So put to a large bore IV line. Okay, that is very important. Because third stage, you will go to hypotension, shock and all. Then after putting IV line, what is the second thing you start for this patient?
A patient is very restless, anxious, and
the practical thing, restless is okay. You put an IV line. Restless, what you do?
We can give benzodiazepines.
Okay, you sedate the patient. That's okay. Next thing is what? This patient had some other problem. That's why I'm asking. She had severe vomiting. PAN. Fluid. See, why you are not telling this? This is most important thing. Don't think that bigger treatments are done in emergency room. You are doing basic treatment. You put an IV line, start fluid. What fluid you give? RL. So you start fluid, then you can sedate the patient with benzodiazepam or some other opioids. Okay. So fluid has to be started. Then
or else
next is flushing. How do you control flushing?
Either we can give alpha-2 agonist clonidine or benzodiazepines also will help.
Okay, benzodiazepine also will help. Clonidine can be started.
Given. For antiemetics, we can give ondansetron, emisset.
Ondansetron can be tried. Okay.
And if the patient is also complaining of abdominal cramping pain, we can give antispasmodics.
Okay. What?
Cyclopam.
Okay.
For muscle cramps, we can give aceclofenac or paracetamol can be given. If it is moderately severe and severe, then we have to give partial agonist.
What?
Opioid partial agonist. Opioid partial agonists are opioid replacement therapy is used in moderately severe and severe withdrawal. Partial agonist binds to the same receptors, but their activity is less. Buprenorphine, starting dose is 8 mg sublingual. We can give additional 8 mg dose if the symptoms are not reducing every 1 hourly. Maximum dose up to 32 mg in 24 hours.
Can we give patch?
Buprenorphine patch.
We give in ICUs. Can we give?
That is for pain management.
Can you give or not? I am asking simple question. It has to be given sublingual. That is a best route in this condition. Can we give patch?
Yes.
Patch. Sublingual is fast. Patch take at least 24 hours. That is a problem. So once you give sublingual, then you can apply the patch for a prolonged action. But it will not be acutely acting.
Or else we can give low dose 0.3 to 0.9 mg IV every 6 to 12 hours.
Morphine?
Morphine again will
Buprenorphine, morphine, all are same. If you don't have buprenorphine, you have to try morphine.
Morphine.
Okay, because that is the only thing available in most of the
hospitals.
hospitals. Buprenorphine is very costly. Sublingual may not be available in all hospitals. So you can try that. Nothing wrong in that, because we have to control the patient.
Methadone also can be given. 10 mg IV or 20 mg orally can be given. Maximum dose is 20 mg IV, 40 mg oral in 24 hours.
Methadone is available in our
India.
state, India? I don't think so. Okay.
Though the withdrawal is not life-threatening but very uncomfortable, patient requires further monitoring and psychosocial support, rehab, counseling and cognitive behavioral therapy. So we had informed psychiatry and patient was shifted to psychiatry ward. Patient was observed.
Even if without vomiting, patient can have hypovolemia? Can patient have hypovolemia in this condition?
Excess sweating and lacrimation.
Excessive sweating is one of the complications. So they can have, even still they can have hypovolemia.
Coming to opioid withdrawal symptom. Opioid withdrawal symptom is that happens after a cessation or reduction of prolonged opioid use in a patient who is physically dependent. Long-term opioid uses causes down-regulation of this opioid receptor, and sudden or abrupt cessation can cause upregulation of receptor and causes neuronal firing. That will.
We are also giving morphine in many patients with cancer patients. Suddenly, if you withdraw that, patient will have similar features.
Withdrawal starts from 6 to 12 hours after the last use of short-acting opioids or 30 hours after the use of long-acting opioids. Symptoms peaks on the third day of absence and resolves by 5th to 6th day. Initially begins with anxiety and progresses to other symptoms. Initial features are anxiety, yawning, drug craving, lacrimation, rhinorrhea, diaphoresis and myalgia. After 12 hours, patient will have irritability, tremors, tachycardia, hypertension, piloerection and mydriasis. After 12 to 24 hours, patients will have insomnia, muscle spasm, abdominal pain, nausea, vomiting and diarrhea. Then according to the clinical assessment tool, we'll have to see the grading and then treat accordingly.
Then what happened to this patient afterwards?
2 days observation was given. Since patient did not have any suicidal ideations, he was discharged with quetiapine 1.2.
Quetiapine?
Yeah.
Okay. Anything else you want to add? So how do you manage a case of withdrawal? That will be very common nowadays. How do you manage? What did you understand?
Initially, we have to take care of airway will not be mostly compromised. We'll be looking into the circulatory part. If the patient is severely anxious and aggressive in the ER, then we have to sedate the patient with benzodiazepines. And then patient has to be started on IV fluids. Then on following that, we have to give some agonist agent, which is long acting and with lesser side effects. So we will be going for buprenorphine mostly in India. And sublingually or IV can be given. And then followingly, we have to give a psychosocial support and psychiatric cognitive behavioral therapy.
Okay. Anything else you want to tell? No. Thank you.
Thank you, sir.